Thank you all for joining us today. Myself, Linda Roman, Senior Vice President of Strategic Account Management at Centauri, and Brian Smith, who's the Operations Director of Analytics and Planning for our Medicare Advantage service line. So appreciate you joining, and we'll get right into the material. For those of you who were on the call at our last webinar, there's a couple of things that may be a little bit of a repeat, but just wanted to make sure you know we are Centauri Health Solutions. Our services are to both the payer space as well as the provider space, and we're expert in government programs, Medicare, Medicaid, commercial, and the exchange, and our services are very reimbursement focused. Our solutions support analytics to identify and execute on those programs that will allow us to assist our clients with aligning your payment with your costs. And so that is what we do. We do have a little over 1,700 employees, serve about 500 providers, over 70 payers, and have been in this space, have over 35 years of government program experience. These are all the services that we provide. On the right-hand side are all the services that we provide to our Medicare Advantage and health plans and Medicaid and expansion populations. On the left side are all the services that we provide to our payer or our provider or organizations. Some of you may have seen a bit of this last month, but I did want to provide just a bit of an update because we only had preliminary results about the 2021 growth. And now that we have February numbers from AEP, it does, in fact, still support the fact that we had an industry growth of 9.9% over February this time last year, which means that we grew Medicare Advantage 2.4 million since February of 2020. Now the program is at 26.3 million lives, as you can see in the chart on the right, still very substantial growth. There were no states in the country where AEP or there were membership losses, so every state either stayed the same or grew, and clearly 63% of the new AEP or the new growth was focused around the 10 largest MA plans. And so clearly just a continuation of what we saw from the January numbers, but it did continue to solidify. I mentioned a couple of these things. I won't spend a lot of time because we have a lot of ground to cover today. In this AEP, we did find that one of the significant things that was all Medicare Advantage members had lots of choices this year. All of them, 9 out of 10, also were in prescription drug benefit plans that included prescription drug coverage, and all of them had significant choice this year. There were a lot more supplemental benefits this year, as we mentioned in our last webinar, many of them shown here in terms of the kinds of things that were increased this year, and many Medicare Advantage plans included fitness and dental benefits as well. So we'll get right into kind of the whole part of the program this month is all around retention of your dual eligible members. So most of you who live and breathe Medicare Advantage know that in 2017, CMS moved to a concurrent payment model. The significance of this for Medicare Advantage plans was that while finding new duals was always important, what became even more critical in the 2017 changes were the fact that for duals that had to recertify on an annual basis, historically, as long as the member, if they lost their dual benefit during the year, they had plenty of time to get it back before the end of the year, before it impacted your payment. In the concurrent model, that changed to be in the current year. So currently now, since that change, anytime a member loses their dual benefit, that does impact you in the current year. So it goes back to the month in which they lost it. So as you can see, CMS now uses a rolling 3 months to identify those members who have lost their dual benefit, still in your plan, but lost the dual benefit, therefore affects your loss of payment of that incremental capitation. So just to give you a little bit of an understanding about how this can significantly impact you, we've just done an example here. Some of the factors are, you know, on a routine basis, Medicare Advantage plans have a fall-off rate each month. The fall-off rate is defined as, you know, the percentage of members who lose that dual benefit on any given month. Some of those losses are appropriate, but many more people lose the benefit just as a result of failure to recertify. So on average, plans have about a 2.5% fall off per month. Also of significance is the average number of months it takes a member to get their benefit back. Historically, we knew that it took about 5 months for a member to fully realize they had lost their benefit, then start the paperwork and get through the process to get their benefit back. What that meant then was that with this change to concurrent payment is that if you did nothing different than you had always done historically, what that meant was that for a plan that had 5,000 partial duals and 7,000 full duals, that meant that when we play these factors out over a year, that meant you had a potential loss in revenue of $1.7 million because of this concurrent change. That was a very significant change to the program. And again, if plans did nothing different, this is what it would look like. It was at that time that our operations team really took a look at what we could do to ensure that our clients and our health plans knew what to do in order to mitigate that risk. And so what we see here, as you can see on the left side of this chart, the chart I just walked through with you, where you have the 2.5% monthly fall off and it being applied to partials and full against that 5 months of lost revenue and the potential loss of revenue that could mean at 1.7 million. Now, what we started was a retention program at that point that was designed to impact not only the fall off rate, but it was also designed to impact the number of lost months of revenue. And so in this case, if we only impacted the fall off rate by 0.5%, and we reduced the number of fall off months to 2 instead of 5, that meant that the savings were over $1 million, so almost $1.2 million of saved revenue as a result of that effort. And so here you can kind of see the impact of, you know, taking a more proactive approach and really trying to make an impact on the fall-off rate and the time that it takes to get a member back into a dual program. One of the things that our program showed us, which was based on a pilot we had done some years prior, was that we could impact that fall-off rate by about half. You can never make it go to 0, but we knew that we could impact it by half because we had done that in this pilot program in the past. And we also knew that based upon the program that we put together, that we believed we could impact the number of months a member was off, get in front of it, get the member recertified as quickly as possible, so that if a member lost member months, it would be the minimal number of months possible. If we applied that logic and over a 3-year period went from a 2.5% fall off rate down to a 1.5% fall off rate, it meant that year over year we would continue to retain revenue for the plan so that we would mitigate that risk for the plan. So at this point, I'm going to turn it over to Brian Smith, who will talk to you about kind of how we arrived at the program that we put in place and what the impact has been.
Thank you, Linda. Good morning or good afternoon, everybody. Hope you're having a good day wherever you are. So as Linda mentioned, I'm going to cover a little bit about how we execute on our retention strategy. And to Linda's point, there's a couple things we're trying to accomplish with our retention program. Number one, we want to prevent a fall off from even happening at all for that member who has a dual status. So that's the number one objective. Number two is if that member does lose the benefit, then we want to help that member regain the benefit as quickly as possible, reduce that time off of the dual status benefit. Number three, we are also looking and mining for folks who are currently partial duals who potentially have an opportunity to move to a full dual status. Under that old model prior to 2017, it did not matter to a member or to a health plan whether the member was a full or a partial dual. Now that does matter for the health plan side. There's some significant, some impact for the member if they get on full Medicaid versus just a Medicare savings program. There are some added advantages there as far as co-pays and deductibles go. But the payment model is significantly changed for the health plan side. So we want to push folks from partial to full dual status if possible. And then the last really prong of our retention program is not only retaining dual status, but helping to improve overall retention of that member within the health plan itself. And we have found that we have been able to significantly impact and improve overall retention rates at the plan level with our retention program. So a couple models for our outreach. Again, this is all focused on your dual population here. The proactive model is what we start off with everybody. So we are doing outreach to all dual members before they ever even lose their dual status. And once accepted into the retention program, if that member says, I do need your assistance, then we're going to re-engage with that member every 90 days. And we have found that this strategy is really effective in helping that member maintain their dual status and improves the overall retention within the health plan. And we minimize the fall off, of course, there. The second prong there for the outreach is a reactive. So if a member happens to fall off a benefit, and this can be inside or outside of our retention program at this point, we are doing immediate outreach to that member to see if we can assist that member in regaining the benefits. So that reactive outreach it's happening after the member loses their dual status, and we are doing this outreach based upon the Medicaid status on the MMR. So I talked a little bit about some of the other, I'm sorry, Linda, jump back real quick. On the overall strategy, what we're doing, we do this engagement through outbound letters that we are sending to the members ahead of their redetermination dates, and then we are combining that with outbound calling. Once the member is accepted into the retention program, that member has to accept it. If the member indicates that they are not interested in us following up with them on a quarterly basis or so forth, they do not get into our retention program, and we status the account as not interested and move on. But if they are, then we're going to let the member know that we're going to follow up with them quarterly, and we get their consent for that. And we also partner with the health plans here to add some additional messaging as we're doing that 90-day follow-up. These can be a reminder message as we make our connection with the member, a reminder message to get your annual physical this year. In the pandemic, in the midst of it, the height of it last year, We had partnered with some of our plans to provide some messaging and reminders that telehealth services were available for the members as well. There was no need for them to visit doctors in person. So we are flexible with providing some of that additional messaging with our partners there. Let's move ahead. Predictive analytics, for those of you who are with us in the first session, we use it not only on our non-dual outreach, but we are using it within our retention strategies as well. So here again, we use primarily the model to help us identify the partial duals within a population who are highly likely to be eligible for full dual benefits. That is our primary use of our predictive model here. We engage with those members, we will screen them and assess them for full dual opportunity, and then assist with that full Medicaid application. So next I want to get into just some case studies here and we got a couple different views that we're going to kind of share with you to show the impact that we've had with our retention program in the real world. The first view here, this is for a larger national carrier, and we were measuring the overall improvement in enrollment retention here for members within our retention program as compared to the folks who did not accept or enter into our retention program. And what we saw over this 2-year period, this was from mid-2018 through mid-2020, you can see very quickly that the overall retention rate was improving rapidly for the folks within our retention program. And a lot of this membership happened to be dual SNP membership as well, so where the member has to retain their full dual benefit to maintain membership in that plan. So again, we saw very quickly that we jumped to about a 16% variance in our retention rate for those members in our program compared to members outside of our retention program within that plan. The next slide here translates that, what you saw in the previous chart, into the dollars that were associated with this. And here we focused on the margin contribution for the members that are in that retention program for us. As you guys know, if the member maintains enrollment within the health plan, the overall payment is retained as well. But we didn't want to measure this based on the roughly $900 to $1,000 average PMPM here. We focused strictly on the margin component, estimated that at about $148. And you can see how fast that revenue accumulates as far as retained revenue for these members that are in the retention program. Again, this was a larger national plan. At the end of the 2 years, we were exceeding 28 million. The next case that we'll share here, this is a more regional based plan, and a little bit more noise as far as the jump up, but overall there was improved retention even at the regional level as well, approaching 10% by the end of the 24-month period. Here we ended at 73% at the end of this 2-year period. 73% of the members in our retention program still enrolled with the plan, as opposed to 64% for the dual membership that was not in our retention program. So again, very significant improvement with this regional plan. And the next slide here is going to show the climb in dollars. Now this view, instead of counting the overall full contribution of each member month, we took what was the dollar difference that we achieved with the members in our retention program compared to the group that wasn't, and we ran it as if the retention rates would have been the same. So at the end of the year, at the end of the 2-year period, what if this group had really been 64% instead of 73%? Measured that at the contribution level, again, using the $148 on average as a contribution to margin. And at the end of this 2-year period, it was over almost $350,000 of retained value for the regional plan here. So you can see very quickly, these are real dollars that can be achieved by improving overall dual retention and retention within your health plans. Here, this slide, I wanted to give you another real world experience. The chart on the left is focused on the movement and the improvement in revenue from moving partial duals to a full dual status. So think of that overall cap payment for a partial dual. It's roughly 25 bucks on average. As a full dual, it's over $200 on average. So if you can push a current partial dual member to a full dual status, if they're truly eligible for full Medicaid, the revenue to the health plan can increase almost tenfold. And so that's what the chart on the left is generating or showing there. This was, again, first year of a retention program for a larger national carrier, what we were able to achieve with pushing folks from partial status to a full dual status, going from 400 grand to over 4 million. And chart on the right kind of recaps some of the stuff Linda went over already. This particular plan started with a monthly fall off rate of 3.5% at the very beginning of our retention program. We had anticipated that we could cut it to 2.75% in year one, and we were actually able to knock that fall off rate down to 2.09% in year one of the retention program. And this, again, with that accumulation of that revenue, it represented over 34.4 million as we continued with this project that we were able to save for this particular plan.
So thank you, Brian, very much. I think it does demonstrate that, and if I recall, Brian, this program was modeled after a pilot that you had done sort of a year or two before this change, where we had done this for a dual SNP program. Is that correct?
That is correct, yes, Linda. It was a dual SNP pilot that we had run back before the model changes even. So this was the old payment model where we ran this pilot, and we were able to cut that fall off rate in 1 year over, cut it in half. Actually, that was over a 2-year pilot, cut the fall off rate in half.
Yeah, that's great. And so the wonderful thing about that was that that pilot then gave you the information you needed to build this retention program that has really turned out to be helpful to our clients for sure.
Exactly.
So I think one of the things, thank you, Brian. One of the things Brian mentioned was that this engagement strategy where we're reaching out to the enrolled members, the dual enrolled members on a quarterly basis, really does allow us to stay engaged with your members and with the members of the plan. And it also allows us to partner with our clients in a way that does sometimes deliver some additional messaging. And so this is a way in which we've been able to partner pretty effectively, especially during the COVID time, where we've been able to assist in making sure members got some unique messaging that the health plan needed, because we get them on the phone, we have them engaged. It's a good opportunity for us to keep the member engaged. So not only does it serve this very important economic purpose, but it also allows us to continue our engagement communications with those members. It does also allow us, I think we talked a little bit about our social determinants program, Social Services Plus, that's available. This also allows opportunities to engage the members on unique social and community-based needs, where as an option, the member can choose to be assessed for social and community benefits, such as SNAP or food banks or transportation, various kinds of programs. And then as the member accepts that program, we're able to assess them with a very short social service assessment. And once the member's needs then are identified, look for specific needs that will look for specific programs that will address those specific needs, not just kind of throwing the kitchen sink at them, but really focused programs that may in fact address a specific need. This is just an example of where we did have a client where we were able to engage them. They were able to get 3 different programs referred to them. Then when we followed up, we found that, one of the programs had maybe run out of funds. And so we were able to find another program for that member. And so this is just a way in which we've been able to stay engaged with those members and provide some of these additional services. Of the members that have been in our Social Service Plus program, this is just a breakdown of some of the kinds of programs we have seen most often identified as extra needs. Housing tends to be nearly 32%, housing type issues, whether it be utility assistance or a variety of types of housing needs. Food insecurity certainly tends to be in one of the highest categories at 26%. And then social supports and financial supports, which obviously kind of the core dual program is designed to help support as well. So just to kind of summarize, I know that we talked in our first session last month in February about how we go find new duals. And today we really focused on, once you have those duals, making sure that you're keeping those duals in that benefit. We have found that the continuous member engagement not only helps the member stay in the plan, but helps the member maintain their benefit on a continuous basis and maintain your revenue on a continuous basis as well. Clearly, those opportunities allow us the opportunities to identify changes in circumstance for the member in case they may then be in a position to be eligible for a full dual status versus a partial dual status. And then also to identify those extra programs that they may be in need of, and to try and identify those resources for the member as well. So we will stop right there, and I will see if, in fact, there are any questions in the chat. I do not see any at this point. If you have questions, feel free to plug them into the chat right away, and we'll try to answer them. However, if no questions appear, I think we will end the conference. I think we're right at time. Feel free to reach out to us if you do have questions that come up after you kind of get off the call. We'd be happy to answer any questions that you might have. Really appreciate you participating with us. We like talking about the programs that work, and so appreciate your engagement with us today. And so thank you, Brian. Thank you, audience, for joining us, and have a great afternoon.
Thanks, everyone.